Hilmani,
Thank you.
who has chosen such a nice topic today to this webinar. I don't know if it's time to start, my dear Dr. Hilmani. We start
So
or not yet?
we have few minutes, 4 minutes
Few
to
minutes.
wait in for others to be connected. We
Yeah,
have some minutes.
I see many names of the colleagues, but maybe they are not yet here.
Yes.
Yeah, yeah. You know, Professor Jallo, the situation for us also in Morocco, maybe Professor Helmani has told you, is it was quite stable during all the four former months, but we have some increasing now in the cases of COVID-19. Of course, as everybody is saying, because there is enlargement of the number of the tests, diagnosis tests, but I think also the increasing of the number of the cases. I mean, through the population. So
Yes, no, I I agree. I think we as our numbers are going up in the rest of the world, I think it's just people are going out, going to work, going to the store,
yeah,
and getting it. I think that's that's it's hard to be closed for forever.
yeah. But did you have this impression in Florida, for example, or other places in the state, the increasing of the number, of course, with the number of the tests, but also later on, some weeks later, the number increased because more people are getting ill, of
Yes.
course. Yeah,
Yeah, I think what's happening is there are people that I think there are asymptomatic people or people that that aren't sick. I think when this first started in New York, everyone got sick and they were in the hospital. Now people aren't sick or they have a little cough or a little loss of taste and they don't realize they have it, and then they go and socialize and give it to other people.
yeah.
In Florida, I can tell you in the first 2 months. Average age, the mean age was about 60 that had the coronavirus or COVID-19. Now it's 29 or 30. So it's a
Wow.
lot of young people.
Yeah, yeah. And the severe cases also increased in the young people in
No,
the same proportion.
I can say honestly, with all the increasing, I think it's milder, not as strong. Um,
Yeah,
the numbers are going up, but the number of people in the hospital is not going up as high as the number of people that have it. So it's much less severe than I think it's much less severe than what was in New York City for
yeah,
us in Florida,
yeah, yeah. Good, good.
which is good, but good and bad.
So at least the hospitals are quite
Yeah.
less crowded than in New York.
Yes. Yeah. There's no concern that the hospitals are going to get full or that we're going to run out of supplies because they still have enough intensive care unit beds, ICU beds everywhere,
Okay, very good,
which is good.
good, good. Professor Hilmani,
Yes, Professor.
we are
We
waiting
have,
to your order.
yes, it's 6 o'clock. So, Mehdi, Doctor,
Yes, 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 yes.
um, you can give some word before the later for this situation. You can.
I am,
I will dedicate this webinar to all colleagues who were affected by this pandemic, and I would like to ask you to give us 2 words for reassure our colleagues.
I'm sorry. I'm so happy to see Mehdi here because I
We
thought
are
that it
all
will.
we are So us, we are all of us. We are happy
Yeah,
to say
yeah.
you will know with us.
Very good, very good.
So,
Great.
Professor Hamlishi, we can start.
Yeah, if you want,
Thank you. Before, thank you, Professor Hamlishi. First, before starting this session, I would like to say some words about these situations. Um, First, our hope for good health to our all colleagues who were affected by this pandemic during this their care work, and our prayer to them for a good recovery. Secondly, this webinar is dedicated for them and hoping them a good health and good care. So, in this session, we would like to thank our speaker, Professor Jalou, thank him for accepting our invitation and accepting to share with us his great experience about syringomyelia, especially idiopathic syringomyelia. My thanks to our master, Professor Hamlishi, who are accepted to animate this session. Professor Hamlishi is well known in Morocco and in all the world. Thank you, Professor Hamlishi. Thank you for Professor Jalou to accepting this session. I would like to thank my dear friend and colleagues, Dr. Hakkou Mehdi, for his engagement and in spite this difficult care situation, he accepted to animate and coordinate this session. Dr. Mehdi, can you give us some word to reassure our colleagues, please?
Thank you very much. I'm very happy to be with you. I'm very well now with the drugs. I start my drugs today. I'm very well, alhamdulillah, and see you soon, inshallah. Thank you very much.
Thank you, and good health for you and for all our colleagues who were affected by this pandemic and who sacrifice their health and sometimes their lives to give help to others. Thank you, Professor Hamlishi, and my thanks to all our participants for attending this session. Professor Hamlishi, you can start, please.
Thank you, Professor Helmani, and thank you, Mahdi, for reorganizing and coordinating this webinar. And thank you, Professor Jalou, again for being with us and having accepted to give us talk about this topic, idiopathic syringomyelia, which is a very difficult and complex topic. There is still a lot of controversy, either in the clinical symptoms, in the pathogenesis, and also sometimes a lot of confusing literature, because of course, in addition to the idiopathic syringomyelia, we have many other complex terms used like congenital syringomyelia, secondary syringomyelia, and so on, and even some terms like syringohydromyelia. So I think that it's not easy to have the guideline either for the diagnosis and especially for the management. And in general, the management is made by a group, by a team of course, of surgeons and other specialties, including, of course, neurosurgeon. And I think that I hope that we will have many colleagues participating in this webinar, because personally, I think that we need, all of us need to learn and to understand this complex pathology, and of course to see how to deal with the management of the patients. And of course, Professor Hilmani, you have with Dr. Hakko, you have chosen a great colleague who has experience in this topic, and I'm very happy to have you and to coordinate this webinar with you, Professor Jallo. I'm sure that you are going to give to all the audience the current information about this specific group of idiopathic syringomyelia. You will tell us exactly what we mean today by idiopathic syringomyelia, but also on the same time, of course, certainly try to put this group inside all the large group of syringomyelia, either as I said, primary, secondary, malformative, and so on. So I think I stop here. Of course, Mehdi is so happy to see you, and I am permanently looking at your face. I see that you are okay, and of course I'm so happy to, and all of us are so happy to see you as usual, and continuing to be so active. So please, Professor Jallo, you have the stage. I mean, you can start your conference.
Well, thank you. I want to thank you all for inviting me and the opportunity to really discuss syringomyelia and idiopathic syringomyelia and its management. I think, I too want to echo everyone's thoughts. I think, these webinars are now the future of education, as much as in-person interaction and opportunities. I think given the COVID pandemic, we really are now learning how to teach ourselves and to partner together, as well as educate each other with Zoom, Skype, or some of the other webinar platforms. And, for me, it's a great honor to be here this afternoon and to discuss, I think, a very controversial topic, syringomyelia, idiopathic syringomyelia, and whether it's hydromyelia, and hopefully be able to cover it all and touch upon some of the more recent literature about this disease process. So in the next 55 minutes, really want to discuss, introduce the topic, discuss the pathogenesis, the pathology of syringomyelia, the classifications that we highlight, we've touched upon, some of the clinical features, that what is the natural history, and how do we manage this condition given its complexity. I think as background, really, the term syringomyelia is really the enlargement of fluid-filled cavities within the spinal cord. You can see that T2 MRI here, and you can see that there's a dilatation in the lower cervical, upper thoracic region that extends rostrally to involve the spinal cord. The term itself, I think, has been around for centuries. Olivier Dangers introduced the term syringomyelia, but really the Greeks were the first ones to call it, syrinx and myelos, meaning a pipe or tube or channel inside the marrow of the spinal cord. There's been confusion, and I think it goes back to the 1800s as well, where Stillings in 1856 described hydromyelia as the dilatation of the central canal that exists. and that syringomyelia really is referred to the cystic cavity separate from the central canal. And I think, when you look at these strict definitions, a lot of confusion arises from this because, are we referring to, and some people still refer to hydromyelia and as a distinct entity separate from syringomyelia. I really think, honestly, the term we should be using is a syringohydromyelia or hydrosyringomyelia. It'll encompass all these syringes, all these fluid-filled cavities, and it'll help us avoid the communication breakdown that may occur. What we can use, some people have used the post-traumatic cystic myelopathy for post-traumatic syrinxes, or the pseudosyringomyelia that for cysts that are associated with spinal cord tumors, hemorrhages, or even necrosis, ischemic necrosis of the spinal cord. I think, again, going back in the 1800s, Chiari's description of the cerebellar descent or the cerebellar malformations and his classification of the Chiari 1 or the Chiari 2 malformation, both were associated with syringomyelia in his report. And you can, what we do know is that almost a little more than 50% of people, children, adults that have a Chiari 1 malformation may have an associated syringomyelia that needs to be investigated prior to any intervention. So I think, what we do know is that, as we've discussed, the syringomyelia occurs in association with a wide array of congenital and acquired conditions. What we do know is that most of the cases of syringomyelia are associated with abnormality at the craniocervical junction or at a localized spinal abnormality. And if we look at Studley's original classification of syringomyelia, and I think this is where we have to, I think it is as pertinent today as it was many decades ago. When you look at it, if you break it down by congenital or acquired, whether it's a craniocervical junction abnormality or a spinal abnormality that results, this is the list that can go from the Chiari malformations all the way to craniosynostosis or even achondroplasia, the myelomeningocele, tethered spinal cords, the neuroenteric cysts, arachnoiditis that may involve the spine, all can be congenital that can lead to the syringomyelia. The acquired, you can see, the question, is it acquired at the idiopathic? Is it because there's something at the craniocervical junction, or is it idiopathic because there's something involving the spine? So what we do know, again, as in addition to the Chiari malformations, these syringes can form in up to a third of patients that have occult spinal dysraphism, close to 50% that may have a diastomatomyelia, or 25% in patients or children that may have a tethered cord. And really, you can see syringomyelia with virtually any intradural tumor, most commonly with the intramedullary tumors, whether it be the ependymoma, the astrocytoma, hemangioblastoma, as typically seen, or even the extramedullary tumors, such as meningiomas, may cause a syrinx, the development of a syrinx. As such, that 2/3 of patients with hemangioblastomas and up to 50% of spinal cord ependymomas have an associated syrinx. Seen here, you can see this was a young adolescent, a 21-year-old boy with his initial presentation of a small tumor. You can see the tumor on the axials, but you can see the extensive syringomyelia that is associated with it. It can also be seen with cysts, lipomas, degenerative disease, spondylosis, non-traumatic arachnoiditis, or whether it be in the spine or in the posterior fossa, can be associated with the syringomyelia. And really, in general, syringomyelia afflicts mainly children and young adults, presenting on average somewhere before the third decade And in some patients that sustain a spinal cord injury, 28, almost a third of them will have a syrinx, or almost half will have some cystic changes or myelomalacia of the spinal cord. The good news is symptomatic syringomyelia is really only reported in less than 10% of this spinal cord injury patients. So pathogenesis, and it is controversial. There are three theories that lead to this, that predisposes to the development of a syrinx. One is the dysraphic theory, as one would expect, the congenital, a defect in the neural tube closure predisposes to the development of a syrinx. And I think that is a very strong theory and holds true for the congenital syringomyelia, but does not support the acquired syringomyelias that do occur later in life. The other is the hydrodynamic theory, and this really is that a disturbance of this cerebral spinal fluid outflow from the third ventricle and the fourth ventricle leads to a pre-syrinx condition, edema associated with alteration of the CSF flow, and the contribution of straining or the valsalvas eventually leads to the syrinx expansion. And the third theory is the pulse pressure theory, is that the repetitive mechanical distension of the spinal cord subsequently leads to the syrinx formation. I think this is probably one of the best papers coming out of Ed Oldfield's group from the NIH, who really looked at syringomyelia that was associated with the cerebral spinal fluid pathway obstructions and spinal cord tumors. And they looked, and it was a prospective study looking at almost 50 patients with either a Chiari malformation or ones that had a tumor. And what they did find is that there's a transparenchymal bulk flow of CSF from the spinal subarachnoid space to the syrinx because of the obstruction of CSF flow at the level of the foramen magnum. And what they did document is that with contrast, the one could see intrathecal contrast entering the syringes and going up to the posterior fossa in the cranium, given the obstruction, and that the decompressive surgery for a Chiari malformation opened up these subarachnoid pathways and thus subsequently led to the decrease of the bulk flow of the cerebral spinal fluid from the subarachnoid space into the spinal cord. And this was a paper that was just published last year in neurosurgery. Now, what we do know is that these syrinxes, when they are present, typically are more likely to occur in the lower cervical and the upper thoracic spinal cord. The syrinx wall on pathology is formed by compressed glial tissue or gliosis, and that there's evidence of Wallerian degeneration, demyelination in the surrounding white matter, and as well as neuronophasia in the subsequent gray matter, as seen here on this postmortem study. In addition, there's an enlargement of the perivascular spaces, and that the vascular changes may be seen around the syrinxes, including hyalinization and thickening of the vessels, hemorrhages, and edema. And that the enlargement often affects the crossing, predominantly the crossing spinothalamic tracts, although many other tracts within the spinal cord can be affected. And this is true as when one sees arachnoiditis or the leptomeningeal inflammation and thickening, you typically will see post-traumatic syringomyelia that does occur. And in surgery, one does see that the dura is firmly affixed to the underlying spinal cord, and that this is very adherent, and that this layer embeds into the spinal cord remnants, entrapping both the nerve roots, the vessels, and that there is neovascularization as well as metaplasia that is seen. an older classification, and I think again, looking at Studley's, this is Millerat's classification of syrinxes, and he really his team broke down to really four. That one was the communicating central canal theory associated with hydrocephalus. There's a non-communicating central canal. You've got the extracanicular syringes, the atrophic cavitations, and the neoplastic. So really had 5 classifications for syrinxes, and that all these syrinxes essentially fit into one of these, with the idiopathic into 1 or 2 of it. As an example, here's a case of communicating hydrocephalus. No evidence of a Chiari that can lead to syringomyelia. So again, the question is this idiopathic syringomyelia, or is this a result of the communicating hydrocephalus? And after this, you can see the dye study, the injection of dye. You can see that the omnipaque or metrozamide flows out through the 4th ventricle, straight down into the syringomyelia, and extends all the way caudally down to the lower thoracic spine. What did happen is after a placement of a ventricular peritoneal shunt, this patient's syringomyelia immediately resolved. So, again, another theory another case that supports the communicating syringomyelia theory. In a recent paper, or really 6 years ago, from Groton, who's looking at a practical and a simplified concept for the classification. Now, I will say again, this team broke it down into 5 subcategories, and it was really the category. It was really based upon, if you look at this algorithm, it was really based upon whether or not there was associated supratentorial hydrocephalus. Was it a hindbrain disorder, or was it really direct decompression of the syrinx because of the abnormality? And they broke it down as, if you look at the syringomyelia here, the cause. Again, the key is trying to determine the cause. Is it the hydrocephalus, and that they term that hydrocephalic syringomyelia? Is it because of the hindbrain pathology? And these are, again, not just the Chiari, but multiple etiologies, whether it be arachnoiditis, cysts, or even tumors, classified as hindbrain. A spinal pathology, whether it be a tumor, arachnoiditis, again, a degenerative process, and this was the non-hindbrain or spinal syringomyelia. And then the uncertain was that if it was if there were ambiguous and there were coexisting other hindbrain or spinal pathologies, and really if there's no other cause for this, whether there's no cause of hydrocephalus, hindbrain pathology, or spinal pathology, then can it be called idiopathic syringomyelia? And this is what I think is extremely rare. And this is the one that's really a diagnosis of exclusion before one can say it is idiopathic syringomyelia. Fascinating, they went on in this paper, and I recommend it to all, is what the treatment and what, and this is the algorithm. The first questions they would ask is there hydrocephalus? Yes, or no. If there isn't hydrocephalus, and they, then they said, all right, let's get the MRI of the spine, and let's look for the hindbrain, the complex syringomyelia, or the non-hindbrain spinal etiologies. And it's really, honestly, as they went down through this treatment paradigm, and you can see that, and if there was no other cause, then we could truly say that it was the idiopathic syringomyelia. And the treatment really depends upon the symptoms, whether we watch and wait, or are the symptoms stable. If yes, just clinical follow-up. If no, then you treat the syringomyelia that we will talk about. Again, very complex, but I think it is a very simple classification for this. with that, the ClinComp in 2018 did the very similar thing. How should syringomyelia be defined and diagnosed? Recommended the imaging of the brain and the spine, ensuring that everyone had contrast enhancement. If there's enhancement in the spine, again, it is not syringomyelia, it's not idiopathic. It could be a cystic tumor. If there's no enhancement, it could still be syringomyelia, myelomalacia, glioependymal cyst. Is there any space occupying effect? Yes, tumor, glioependymal cyst is the leading diagnosis. If not, then it could be central canal dilatation and myelomalacia. If that cyst increases with time, yes or no, then it's a glioependymal cyst, or it could also be a cystic tumor, syringomyelia. If not, it's going to be your myelomalacia. And again, a very good algorithm in this paper in World Neurosurgery. And I think, the key is looking at CSF flow obstruction and flow signals inside the cyst. If there is no CSF flow or flow signals within the cyst, one would say it's a cystic tumor or central canal myelomalacia. If it was, then it was your syringomyelia. So I think really, the other thing is defining congenital syringomyelia from the neoplastic. And as we said, looking at the contrast, typically the syringomyelia cavity is continuous slit without any transverse bands or septations. The intracavitary MR signal is identical to that of CSF and the subarachnoid space on both the T1 and T2 images. These typically, they could be associated with neoplasm, that these can have a proteinaceous content and have brighter or darker signal on these sequences as compared. So I think, looking at the clinical features, I think, the first clinical description was done in the 1800s by Portal, who recognized that these patients with syringomyelia had progressive sensory loss and paralysis of the limbs of a servant that was associated on the postmortem study of a cystic spinal cord cavitation. And it was really in the late 1800s, early 1900s, that the classic syndrome of the spinothalamic tract, the dissociated sensory syndrome of pain and temperature loss with preservation of light touch and proprioception, and that this progression is very gradual at best. And so the initial symptoms typically, as you can see here, and you can see the anterior spinothalamic tract on this slice of the spinal cord and the syrinx present, it's segmental pain and sensory loss. The pain is dull, aching, burning in nature, reflecting injury to your pathways of the spinothalamic tracts. And that the compromise of these crossing fibers is one of the earliest clinical features of central cord cavitation, and that the pain is typically at or above the level of injury, can be mild or severe, constant or intermittent, and that coughing, sneezing, straining can exacerbate this pain. And that now the dissociated sensory loss is the ascending segments is more common than a complete loss of sensation, as you can see the crossing pathways and the presence of a syrinx here, and that this progressive asymmetrical weakness tends to occur after the onset of sensory symptoms, and that patients will typically report a gradual loss of motor function above the level of a previous injury. There's also evidence that spasticity is worse in patients that have a spinal cord injury that are associated with a syrinx as compared to those that do not have a syrinx. Other associated signs and symptoms include some reduction of reflexes, autonomic dysreflexia, higher location could be a Horner's, and even in the younger children, some cardiorespiratory dysfunction. In rare cases, this syrinx can extend into the brainstem and cause some bulbar symptoms and signs, and that this progressive intramedullary cavity expansion can lead to compromise of the anterior horn cells, resulting in a lower motor neuron presentation for the upper extremities, and that the lateral expansion results in compromise of the corticospinal tracts that may lead to some spasticity or some spastic paraparesis. The dysautonomia typically, although extremely rare, is a result of the sympathetic fibers, and that this neurogenic arthropathies are typically seen in the older individuals rather than the young children. Cauda equina syndrome can be associated in some patients that have the syringomyelia focal to the conus medullaris level. Here is one with a Chiari malformation. You can see this associated syrinx, not with a, as we discussed, some gaps between the two syringes that are present. Here is one syrinx or cyst that's associated with this spinal cord ependymoma. And you can see here, again, another patient that had the two syrinxes without any associated. Now it's your idiopathic. So looking at this paper, at the presenting features, what we do, what the biggest complaint that of their patients, what they had was patients had some headache, nausea, some back pain, paresthesias, anesthesias, and bowel bladder dysfunction, and they were associated with some deterioration in school performance as well as some congenital deformities. So what is the prevalence of this? You know, typically it's 8 individuals of 100,000. The natural history is not well established. The symptoms may progress for a few years, then remain static, or there may be a slow, intermittent, or continuous deterioration. Most patients tend to, fortunately, have a very slow progression or very little to no progression of their signs and symptoms. And in one small observational series, close to 20 to 50% of patients had static symptoms without any treatment over 10 years or more, and that there are some reports of spontaneous resolution in both children and adults of the syringomyelia, and it may be due to decompression of the syrinx into the subarachnoid space. So here's this is I'd say one of the older papers that looked at the natural history of untreated syringomyelia in pediatric patients. And what they did was they looked at it at the Children's Hospital in British Columbia. And what they had was they had 17 patients that were enrolled in the study. And you can see that there, as one would expect, a very small percentage had symptoms. 2 out of 17, 3 out of 17 had sensory headaches, some mild motor deficits, and more had the intermittent incontinence. And what they did was they followed these patients, and what they found was that the syringomyelia often remains stable in patients receiving non-operative treatment. However, in 2 of the 17 patients, the syrinx enlarged, and it really, the syrinx, these 2 patients both had a Chiari malformation, and that what they felt was that it is very appropriate to include the periodic imaging in the follow-up of patients that present with syringomyelia in children. This is a more recent paper that looked at isolated syringomyelia, again, in the pediatric population at a single center. And they looked at 39 patients. The mean age was 11 years. The average syrinx diameter was about 3 millimeters, and the length was spanned on average somewhere between 19 vertebral bodies. The majority, 3/4 of them were in the thoracic, and that 3 involved the cervical thoracic, and 6 the thoracolumbar, and only 3 were in the cervical. And that 1/3 of these patients were found incidentally during the workup for scoliosis, and that's what one would expect. You know, we find these. I typically see these adolescents referred to our practice because they've got scoliosis, and the orthopedic surgeon obtains an MRI and finds a syrinx and makes the referral to the neurosurgery practice, asking for clearance for surgery or not. And typically, I would say that all the patients that I see are all asymptomatic from their syrinx and do not require any treatment. And I think really, as we said, 11 were worked up for idiopathic scoliosis, and it was found, the syrinx was found incidental. And of the 14 patients, 11 remained asymptomatic. So 3/4 on follow-up did not require any other treatment, and another 3 were lost with that. The other presented with progressive back pain is the other referring symptom. And of these patients, that there's really no treatment for these except for a lumbar puncture. And I've read this paper several times and I don't understand it, but their recommendation is that in most of these idiopathic syrinxes is a benign pathology and can be managed expectantly. Most cases will remain stable or improve. A small minority that are symptomatic, they recommended a lumbar puncture. I don't do that in my practice, but I may start considering that in the future practice. And then another paper looking at the management of this idiopathic pediatric syringomyelia, again, all single institution studies, and they looked at and classified it as uncomplicated idiopathic syringomyelia or idiopathic syringomyelia associated with scoliosis. And they looked at their clinical course as well as their radiological imaging course. They had close to 100 patients in this series. Again, the young age of about 12 years. Maximum syrinx size was about, a medium size was about 2 millimeters, spanning 5 vertebral levels, and about 38% had scoliosis in that group B category, and that they did have follow-up for a minimum from somewhere from 2 months to 83 months, and that in 3/4 of the patient there was no change in the syrinx, and 16% had a decrease, and only 8% had an increase in the syrinx size. And that there was a concordance between the clinical and the radiological course, showing that patients that did have an increase in the size had progressive clinical symptoms that required. So I think, really the conclusion of this paper is that this idiopathic syringomyelia in children that have associated scoliosis is somewhat complicated, but there's really no concordance between the size of the syrinx and the clinical deterioration in this cohort, and that really the decision-making should reflect the clinical course as opposed to the imaging course of the syrinxes. So next comes, what is the treatment for these syringomyelia in patients that are symptomatic? I think, what's clear, honestly, is that if it's an acquired syringomyelia, the treatment to treat the syrinx or the syrinxes is directed towards identifying and treating the underlying cause. I think there's no controversy about that. All the authors, all the papers that I presented confirm that if it's associated with the tumor, do the tumor. If there's a Chiari or hindbrain malformation, address the hindbrain malformation. And as seen here in this, looking at the etiology of Chiari, 70% basilar invagination, post-traumatic or tumor, before one considers shunting of the syrinx. And I was going to talk about how do I do it, and what I did find was that this recent publication, 2019, out of Shlomi Constantini in Israel, that really is the technique that I employ, and it's interesting. I think we were both trained by Fred Epstein, so I think we both approach these syrinxes in a very similar fashion, and as seen here. One is, for these idiopathic enlarging syrinxes with associated clinical symptoms and no underlying etiology. The treatment is a syringo-subarachnoid stent or a single subarachnoid shunt, typically looking at the widest diameter of the syrinx. So if it is largest in the thoracic region, I would address that thoracic region. If it's wider in the cervical region, I would address it in the cervical region. Open up, typically do a 2-level laminectomy or laminoplasty. We'll ultrasound before opening the dura to ensure that there is a syrinx present. Open the dura, perform a small myelotomy, place. What I like to use is I tend to use the lumboperitoneal shunt tubing, or when I was in New York, we used to use the myringotomy tube, a very small tube, place it within the syrinx, and then place the distal end within the subarachnoid space. You can see here, preserving the arachnoid at time of opening, because we want to ensure that's placed in the subarachnoid space, and then suture this tube to the pia, or he sutures it to the arachnoid. The question is, where do I do the myelotomy? Typically in the midline, but if it's an eccentric syrinx, more eccentric to the to one side, I tend to do the myelotomy where the syrinx comes closest to the surface of the spinal cord, to thus traverse as little normal spinal cord tissue as possible. And you can see this here, the myringotomy, the tube is placed, as well as the myelotomy there in this case. And again, I think, when we talk about this, the question is, there was another paper looking at this technique in World Neurosurgery in 2018, and they looked at 41 patients that underwent a syrinx to subarachnoid stent or shunt for syringomyelia. Some were associated with spinal, again, not just idiopathic, but as one would expect, could be associated with arachnoid cysts, adhesions, tether cord, or Chiari. And what in their series, what they found was that really this procedure is safe and effective with minimal risk of new deficits. There were several cases of the shunt or the stent dislodgement, but there were really no cases of blockage or infection in this procedure. So I think, for me, what do I think? How do I think about when I see this? One, when I see a patient, whether it be a child, an adult with syringomyelia, I want to determine the etiology. Is this idiopathic or not? I get a MRI of the brain, cervical, thoracic spine with contrast. I also do a lumbar spine MR to ensure that there is no tether cord or lumbar pathology. And if this is all normal, I typically follow the natural history course and just assume that they're going to be indolent or benign. I will do the next follow-up again in about 2 years' time if they're asymptomatic, just to compare the syrinx. If there is no change in their clinical symptoms or on the radiographic imaging, I then just see them expectedly in the office maybe every 5 years or so without any imaging, unless they have progressive clinical symptoms or new symptoms that they may describe. And that is my management for idiopathic syringomyelia. In the very select few cases that I've treated, I've done that technique of Constantini with the syringo subarachnoid stent, and that seems to have worked well. I have never done a syringopleural or syringoperitoneal shunt for idiopathic syringomyelia. The only times that I've performed a syringopleural or syringoperitoneal shunt is in those cases where there is syringomyelia that is associated with arachnoiditis, post-traumatic, post-subarachnoid hemorrhage, or post-tethering. Because in those cases where the subarachnoid space is not patent and does not allow for normal flow of cerebrospinal fluid, a syringo subarachnoid stent or shunt does fail, and one is better off performing a syringopleural or a syringoperitoneal shunt in those cases. And I do want to thank you for your attention this afternoon, this evening, and shukran or mercy. And I will be available to answer any questions.
Thank you. Thank you very much, Professor Jalou. You hear me?
Yes, I do.
Yeah. It was a really very clear and a complete talk on syringomyelia. I was very happy to see you speaking on all the topic of syringomyelia from the beginning, because when I have seen on the webinar idiopathic syringomyelia, I was quite afraid that you limit your talk to the idiopathic group, which is, as you have shown us, quite rare and mainly in pediatric population, and which maybe rise, of course, some problems of the treatment, but the other group of syringomyelia are more frequent and quite more difficult to manage with a lot of also complications when you follow up these patients for a long time. So it was really a very didactic and very an excellent presentation. Now, you have clearly said that in idiopathic group of patients, mainly which are symptomatic, you are using only the syrinx subarachnoid shunt. And you have shown us this very interesting review of the literature, and you have seen even in this paper that the follow-up was starting from 3 months, three months to 100 or something like that, with a mean follow-up of 36 months. And what do you think about in this pathology when the follow-up is longer? Because one of the problem with this syringo subarachnoid shunt is, of course, the associated arachnoiditis and adherence in the area of the syringomyelia, which is in general, most of the time is there. And many surgeons have advised to try to dissect this adherence. But anyway, we know that this adherence come back, except if, of course, the flow of the CSF is well maintained. So what do you think about when you see the patients more with the large follow-up in this group of syringomyelia? Now, can you also tell us, in your experience, about the long follow-up of this other group of syringomyelia? Because the Chiari, the posterior fossa decompression for Chiari, or shunt for hydrocephalus, I heard also that some series were treated, the hydrocephaly was treated with what ventricular cystonostomy endoscopy. which is not easy to understand regarding the pathogenesis of the hydrocephalus. And also of these cases you have shown with the communication, when we have a communication between the fourth ventricle and the syrinx. What about the is there any specific treatment in addition to the treatment of the cause, which is the decompression and the dissection of the arachnoid, the adherence surrounding the syringomyelia? So these are some, I'm sorry, some point which I think are important to clarify for the colleagues who are following this webinar, because as I said, they would like to have as much as clear guidelines to treat these patients and this pathology, which is really disturbing, not easy, and we understand it with the experience and with the long follow-up of the patients.
No, I think those are all excellent questions. I think this is a very controversial topic and a very complex topic. I think, you know, there is so many different ways to treat this condition that I don't think any one treatment, I don't think my treatment is the best way. As an example, when I was training in New York City with Fred Epstein, all our Chiari patients that had syringomyelia, we would do a posterior fossa decompression and a laminectomy for a syringo subarachnoid shunt or stent at the same time. And I think, you know, when we looked at that, I think when I looked at it, we had close to 70 patients that we did this in. What we found was the patients that underwent both procedures, the syrinx resolved completely. In the patients that we only did the posterior fossa decompression, there was a small percentage that the syrinx did not go away, and we subsequently had to address the syrinx directly. So that was my training in New York. When I finished my training and I moved to Baltimore, I immediately moved away from doing the syringo subarachnoid stent for my Chiari patients. I went straightly to a posterior fossa decompression and said, you know, it's just a small number that this may not work. If it doesn't work, then I will, I'd rather take a risk at a second operation rather than doing it all in one sitting. What I can tell you is that the patients that I did in New York, and the reason I moved away from it was I was afraid about the arachnoiditis, the focal arachnoiditis that develops around the syrinx, or the risk of infection. We had no infections. We had one or two patients that did develop arachnoiditis or tethering around that stent. And for that reason, when I was in Baltimore and today, all my Chiaris with syringomyelias, I just do a posterior fossa decompression. And fortunately, I've been blessed. I've only had to address the syrinx once in the last 20 years to avoid that. It is a known risk. You know, every time you do an operation, there's going to be a risk for scar formation. What I did find, though, is I tended to have more scarring in those patients that I would do a syringopleural or a syringoperitoneal shunt. Again, I think that, and the reason for that is my technique for those was I would place a T-tube into the syrinx and then bring that out through the dura and then connect that to the valve and then into the distal the peritoneal or the pleural catheter. And what I found in those cases, and again, it was different etiology. Those were more, whether it was more of a tethering or more of a arachnoiditis case. Those cases, I'd say 100% of those tethered. Fortunately, very few of them had reaccumulation of their syrinx and a progression of their symptoms. But there are several that did require re-exploration of that syringopleural or that syringoperitoneal shunt. So again, it's not an operation I would take lightly. The other key is preserving the arachnoid if you're going to do the syringo whatever shunt. By preserving the arachnoid, the hope is that the spinal cord itself or the tube itself will not get stuck to the dura and that if it stays within the subarachnoid space and the arachnoids close properly, that the CSF pathways, if present, should hopefully prevent the formation of tethering and scar tissue. So, so I think, you know, again, it is not an easy decision. Now, as an example, if I do a Chiari decompression with syringomyelia, the syrinx goes, you know, resolves, and then over time, if the syrinx reaccumulates, before I address that directly with the syringal subarachnoid stent, I focus on the hindbrain or the posterior fossa, assuming that there is going to be scar tissue there, and I will address that. And at the same time, what I usually tell the families is, if I'm going to reoperate on the Chiari, if I don't see scar tissue or adhesions, then I will drop down and do the syringal subarachnoid stent for them. But fortunately, that's been far and few between. So it is a, you know, I think we have to be very careful about the indications. And as I said, you know, I will follow these children and young adults conservatively, regardless of how big the syrinx is, as long as it's not enlarging or that they have no clinical symptoms. I'd rather watch it before I address the syrinx. It's only that it's really on subsequent and serial imaging that's enlarging, or that they're starting to show some clinical signs. Would I address it with address the syrinx directly? So hopefully I was able to answer those questions.
Yeah. Thank you very much. Thank you.
The other question I see here is, you know, scoliosis and the syrinx. Is it the syrinx that causes the scoliosis, or is it the scoliosis that causes, you know, the syrinx? You know, I look at that and I say, you know, it's like the chicken or the hen. Which came first, the egg or the chicken? And you know, I think honestly, I think in most cases, I don't think, you know, in my experience, I don't think it's the syrinx that's driving the scoliosis. The only times I would say the syrinx is driving the scoliosis is in those cases where it's a large syrinx and it's a rapidly progressive curve. But in the majority of my practice, the syrinxes that I see that are referred from orthopedics, it's a idiopathic scoliosis, slowly progressive, and it's a very small syrinx. I mean, it's a extremely small syrinx. So I can't say that it's the syrinx that's driving the scoliosis.
Okay, thank you very much. I think that there should be many other questions. So it's the topic is open now to the questions. Professor Hilmani, Dr. Hako, yeah?
Yes, no, there is. I think first I would like to thank Professor Jallo for this overview and this very nice presentation about this topic. It's difficult, as Professor Khamishi said before. It's very difficult and challenging disease. I think that it's very difficult for us to choose when to expectative treatment or operate some patients. My question before give my question, I would like to. There is one question for Dr. Sako. Did you recommend MRI for all patients who have scoliosis?
No, for idiopathic scoliosis, you know, if they fit the age, female, even a young male in adolescence, I don't recommend an MRI. I don't routinely do MRIs for all scoliosis. It's the ones that may have the atypical findings. You know, sometimes if they have a little hyperreflexia or some other subtle signs, those are the only indications for an MRI and scoliosis.
Okay, my question now, for evaluation of this not evaluation, did you evaluate this idiopathic disease only by a MRI, or there are other assessments?
I usually, I mean, what I typically do is an MRI of the entire neural axis with contrast, brain, cervical spine, thoracic spine, and the lumbar spine. I sometimes, again, when I get referred, some of these children may, or adolescents may have some bladder. They're coming in with bladder complaints or urinary incontinence. In those cases, I will do urodynamic testing, and I'd say 99% of the time they've all been normal, even though they have complaints of some bladder issues.
Okay. Thank you. I ask all our participants if they want to ask Professor Jallo, raise their hand, please. Professor Ouammou, welcome. Professor Bou Youssef. So I continue about my questions. When you decide to operate idiopathic syringomyelia?
For me, it's the symptom. One, progressive symptoms. Two is progressive enlargement on MRI scans. So it's both that I want to see before I operate. I really I try to avoid the surgery on the syrinxes as much as possible. And I will tell you honestly, I mean, we've been fortunate, and those two papers say the operation is safe, and it is a very low risk procedure. What I can tell you though is I've had to manage several patients that had their syrinx operated on elsewhere, and these patients have profound deficits. Some were quadriplegic from a operation. So I don't know. Again, I'm not sure what occurred at time of surgery, but there are some people. There are complications that I haven't personally seen, but I've managed some of these complications. So I am very judicious and very careful about this.
Okay.
Yeah, I think that this problem of decision making regarding surgery in this disease is a very difficult. So you have many patients who come to see you for some subjective symptoms.
Yeah.
They have some headache, they have some spine pain, some fatigue, and on the imaging you discover that there is a syrinx, and there is maybe even grade 1 chiari malformation. So is it in your experience, do you continue to control these patients until to have some objective neurological symptoms and imagine evolution, or what do you think about those who are saying the goal of the surgery on this disease is to stabilize the patients and not to look so much to the improvement? So
Correct.
it's maybe better to operate them earlier. But we know that when you see many of these patients and you follow them, it's not always true. This is very important question. Sorry to ask about these details, practical details.
No, I think those are excellent questions. So, as an example for me, if I see someone with a Chiari malformation and the syringomyelia, if they do not have the classic symptoms of the Chiari, if they have frontal headaches, I don't think those are associated with the Chiari. But if they have the occipital headaches that are worsened with Valsalva, I will recommend surgery for those. For the frontal headaches, Chiari and a syrinx, I will watch them until they either develop what I think are classic symptoms or that there's radiographic progression of the symptoms before I do surgery on those patients. And the same thing with a spinal cord tumor. If it's incidentally found, spinal cord tumor with the syrinx, I typically don't recommend surgery just based on the radiology. And you know, is that the right answer? I can tell you that many people would probably recommend surgery. I think for me personally, I've seen, you know, been fortunate to have had very few associated complications, but I've seen complications with the simplest operation, and I'd rather, it's hard for me to make someone better than they currently are if they really, if I think they are truly asymptomatic.
Other questions?
Yes, one question of the chat about from Dr. Belhashmi about, you know, Professor Jalo, that there is some papers about occipitocervical fixation in syringomyelia. This
Yes.
is the question,
you know, again, I think, you know, I think that's Atul Gul's in India. That's his recommendation for the occipital cervical fusion. You know, when I read his papers and when I've spoken to him, it sounds extremely convincing. And I think he may have something. I'm just not sure. I'm not convinced yet. I think I am. I guess I'm a little more conservative, and I want to ensure you know what his long-term follow-up is with those patients. But you know, he and I think there's a couple other people that are starting to do it now. So I think it's starting to catch on.
Thank you. Another question from Dr. George Salazar. Have you ever used a double syringomyelia subarachnoid shunt in a cross-link manner?
Yes, I have, and this was really for post-traumatic syringomyelia was the only indication that I've done the double shunts for. I don't advocate for it, but I wanted to do everything at the first operations, not wanting to come back, and I didn't think that the one shunt, the syrinx shunt, would work, so I did a double on that patient.
Excuse me, Professor Jalon, may I ask what was the indication in this post-traumatic syringomyelia? Because a double shunt, because already one shunt is questioned, because most of these people have already severe myelopathy, and it's quite difficult to see what is the evolution secondary to this new cyst and the sequela of the traumatism. So
I think great
to manage these cases, because it's very difficult problem.
So I think excellent question. I think, you know, when I look at it, I don't recommend it for every post-traumatic, because I think, as you said, most post-traumatic, there's going to be a progression of symptoms. This was he was a paraplegic individual following, it was a lower cervical high thoracic injury, was in a wheelchair, and the injury occurred 5 years prior, and he had stabilized. And then over the ensuing years, he was losing hand function, so couldn't control his wheelchair, motorized wheelchair anymore. And what you can see is that you can see the myelomalacia at the level of the injury of the spinal cord. And he had been fused previously, but you can see that there was a syrinx that developed, I'd say, about post-trauma year 2. And over the next 3 years was starting to get larger and going up, ascending up into the brainstem. So to me, that's probably the only indication in these post-traumatic cases. Someone that's had an event many years ago and is starting to lose function higher up, and they need that function to for them to be somewhat independent. And that was, the goal was to preserve his hands that he was losing so he could operate his motorized wheelchair.
Thank you. Very good. Yeah.
But I mean, honestly, I've seen many patients post-traumatic syrinxes that develop, if their symptoms are stable or not, there's no progression of symptoms, there's no indication for surgery. There's nothing that you're going to gain by treating that syrinx.
Okay, thank you. Professor Hamlishi, we have one other question or two other questions.
Yes, please.
From Dr. Bulhrud about following, especially asymptomatic patient, at what period and how to manage these patients?
So the first time I see him, I get the entire brain and spine imaging. Once I have that with contrast, I bring them back 2 years later, and I just do a very quick non-contrast MRI just to look at it. And really, for me, it confirms that it's not changing. I can reassure the family that it's not changing. And then I say, just come back every 5 years for a quick check-in just to follow your symptoms, and then maybe consider an MRI at that time. If they develop symptoms, then I see them sooner. But otherwise, I tend not to image them often at all. So first MRI, another MRI 2 years later, and then after that, it's only when they develop symptoms.
My question now about subarachnoid shunt. What the diameters of the shunt and how to orient it cranial or caudal throughout syrinx?
That's a excellent question. So some people I use the lumboperitoneal shunt. So it is half the diameter of a ventricular catheter shunt, and I've seen people use that, but I think those are too big. So the lumboperitoneal shunts are about a half or a third of the diameter of a ventricular shunt. The way I like to place them so either in the middle or where it's widest, the syrinx. I put the catheter in the syrinx, typically going up to the head rostrally, and then I place the distal, the subarachnoid catheter caudally down, going towards the feet. Now, that's 99% of the time. A small percentage of time, I've had to place it up because for some reason or the other that, I'm doing something and I just open at the very bottom of the syrinx or somewhere, and it's easier for me to pass the catheter up than down. But typically, the catheter in the subarachnoid space goes to the feet. The catheter in the spinal cord goes up.
And have you any experience about elastic shunt who allows permeability throughout the syrinx and the subarachnoid space?
Yes, I've seen those. I've never used it, but I've taken them out in some cases where I've had to redo them. This elastic tube. I think they're very reasonable. I'll tell you what I've seen is I've seen someone put a stent to hold the spinal cord open, like a little clip in there, just to hold the spinal cord open without a stent. I've seen that as well, but I really don't have much experience with those.
Thank you. Thank you very much for your answers.
Professor Jallo, may I ask another question? We have still some time, Professor Hilmani, or we have to stop the discussion?
We can continue. Have a few minutes, 10 minutes. Yes.
Professor Jallo, you have certainly followed pediatric patients with this quite frequent ependymal canal dilatation, which can take a form of syrinx and extending more than 3, 4, 5 even levels, vertebral levels. So in general, it's known that they they very rarely increase on the size and rarely become symptomatic. Have you seen cases who become symptomatic, and in which proportion?
The ones I've seen become symptomatic, and it's very few patients that become symptomatic they followed. It's the ones that have had the cervical syrinxes that extended up into the cervical spinal cord. Again, I have no data that would support that. That's just personal experience. Typically, the syringomyelia that involves the cervical thoracic spinal cord are the more likely to become symptomatic than the ones that involve the thoracic spinal cord.
Thank you.
Thank you. Another question, if you allow me, this about pediatric disease. There is what the prevalence of syringomyelia in the pediatric population, and there is any difference about futures about in the adult.
I think it's probably more prevalent in the children than it is in adults. I will say, it's reported in 8 to 10 per 100,000, children and adults. In my experience, I think in children, it's probably closer to 15 children per 100,000. And I see a lot of children that have, this what they would call as idiopathic syringomyelia. And I would just classify it as mainly a dilated central canal. So I think in the children, we tend to see very milder forms of the syringomyelia, very small syrinxes that measure less than a millimeter and is seen on 2 or 3 vertebral body levels.
Okay, so if there is there any other question from the audience, or if not, just I will of course give you the conclusion, Professor Hilmani, and just I would like to say to Professor Jallo that I was very happy to coordinate this webinar. You have given us an excellent talk and very informative discussion. I think all of us have learned a lot about this disease, this complex disease again. And this was a very good link and bridge between Florida and American neurosurgeons and Moroccan and North African neurosurgery. I hope that we will repeat it again many times. Of course, the merit gone to Professor Hilmani, the president of the Moroccan Society of Spine Cord Surgery, and Dr. Hakku, who organized this webinar. So it was a great pleasure for me to coordinate it, and I hope, Professor Hilmani, that with Professor Jallo, on this discussion, we reached your objective by choosing this topic, and we are looking for the next one, for another form of syringomyelia or spinal cord malformation or any other neurosurgical topic. Thank you, Professor Jallo. Thank you, Professor Hilmani. Thank you, Dr. Hakku, and thank you all the participants. So the conclusion is to you, please, Professor Hilmani and Dr. Hakku.